All right, but just think of it. Of $4.5 billion, if 30% of it is unnecessary care, and we could save that and share half of it with the primary care docs, who's going to be making more money in the future, the primary care or the specialist? Because it's going to be all that specialty hospital procedure stuff that gets squeezed because it's not necessarily needed, and it's going to be avoided. Now, we'll come back to it on the episodes because we're already putting it in place on some of the episodes. But for the primary care doc on the patient-centered medical home, the future huge revenue opportunity is being the quarterback in managing the system again in a way that we've been nickel and dimed over the last 20 years to where primary care is not an attractive place for many people to consider going. What I think I'm trying to say is it's about to pivot, and it may be very, very different in the not-so-distant future. In fact, anybody here from El Dorado? No Eldoridians? There we go. The Southern Arkansas, I've forgotten what they were, Southern Arkansas Medical Associates, and they just changed their name, are one of those clinics back here on the previous slide. And they have actually taken their money. They make about $500,000 a year in these extra payments. And they've knocked walls down in their clinic. And they've actually organized, they have a 5-doc practice. I think they have a 4-doc practice. They're hiring a 5th. With each doctor, they put a nurse practitioner, they put a health educator, they put a care coordinator, and they put an RN. So they are operationalizing team-based care. Patients are assigned to a team. Each team actually has gone to the point of they wear different colored scrubs. So there's a red team and a blue team and a green team. And guess what? The patients come in and they say, I'm on the red team. And you notice I said, I'm on the red team. They didn't say, I'm cared for by the red team. They're part of the team. Because the nurse practitioner is available when they call in so that the physician doesn't have to see them if they've got chronic urinary tract infections and they need a refill on their antibiotic. The nurse practitioner takes care of that, so they don't have to see the physician. So it's team-based care in a new structure with new money up front to help make the transition and a guarantee from Medicaid that for every dollar you avoid of waste, we'll give you 50 cents. All right? That's out there right now. These 69 practices will start that gain sharing opportunity in 2 years. They're doing the transition now. And we've got this. We've got a solo practitioner in Clinton who's got 2 nurse practitioners with her. And the hospital called and said, where are you sending your patients? Because you're no longer hospitalizing here at the Clinton Hospital. And she goes, I'm not having them go anywhere. They don't need to be hospitalized. All right? So big time difference. Yes, sir?
How do you deal, especially with people who have been in the game for a while, either as patients or physicians, with the trust issue of I'm 56 years old, or I've been practicing for this, I've always seen a doctor, I want to see a doctor, and now you're telling me that I have to see a nurse or something like that. How do we do both the patient education, that that's okay, and the physician education, that it's okay to let that go?
Great question, and I hope everybody heard it, but just to paraphrase, how do we deal with the trust issue? And there's a trust issue both of patient to clinician if it's not a physician, and it's also a trust issue, I'll add a little bit, within the team of who's good enough to do what on the team. You know, I think this is where, you see now the specialist using nurse practitioners a lot. There's a lot of delegation to the nurse practitioner in the specialty area. Why? Because the specialist time is more valued, and for the most part, as long as the patients know the physician specialist is backing that nurse practitioner up and trusted, most of the time the patients are willing to see that nurse practitioner for the less complicated issues. I think we are seeing that in these 69 practices, that as the patients get more comfortable with a new system, and let's just go back to fee-for-service for a second. Part of the challenge is fee-for-service only pays you when you, as a physician, have the patient in front of you. Okay, I don't get paid for talking on the telephone to the mom at night. I only get paid by saying, come in and let me see you. Now, I'm not saying that we as physicians have necessarily abused that financial requirement, but I am saying we never have had an incentive to invest in talking to our patients over the telephone or actually letting a nurse practitioner deal with some of those issues that could be managed without having to have a face-to-face. Oh, and let me go one step farther, and this, again, I get somewhat heretical. I might get fired here in the next 5 minutes, but pediatrician, forever. Kid has an ear infection, I'd say, let's set another appointment up to come back in 2 weeks. I rarely had a mom who didn't know the infection was over when she came back in 2 weeks. Conversely, I rarely had a mom that the infection wasn't dealt with that waited 2 weeks to come back to see me, right? I mean, if the infection's not going away, they're coming back a lot earlier than 2 weeks. So this whole issue of trust, using a team, health education, building the team so that I think part of the issue in the elder rated clinic where they're using the same color scrubs is to have the patient feel like I've got a team working for me, not just an isolated doc or an isolated nurse practitioner or an isolated pharmacist. It's a team, and it is going to be an educational process both inside of the clinical team and with the patients. But I think what we're seeing, particularly when, I mean, I've got 2 staff members who have randomly found an electronic family practice clinic, or a family practice clinic that they're using for their family that is totally electronic here in Little Rock. They were in Wisconsin and came down with pink eye. They called, or I can't remember if they called or they emailed, and the clinic got them a prescription in Wisconsin without having to go into some doctor that they didn't know because they trusted the patient's knowledge because they'd had another kid with pink eye before. And they had a team-based care. They said, if it's not better in a day, call us or go see somebody. So trust is going to be an incredibly important thing. And I think, candidly, we've lost a lot of the trust because of the way the insurance system has worked in the past, where people think that we're making decisions based upon what financial incentive we have to use this drug or refer to this doctor or that doctor, or use this hospital or that hospital. And in the future, I think it's going to be you as the quarterback, do what's right for the patient, and you as the quarterback, make sure that the right outcomes happen, and you're going to make more money and get reinforced in that. But I think it's an excellent question on the trust side with the patient. Let me come back to it on the upper respiratory infection episode in just a minute, because that's another place. Compliance is a big issue that we'll come to. Now, just to give you an example of how this could work. So in Arkansas, y'all have all taken care of patients with congestive heart failure, so I don't have to explain how that works. But we have one of the highest rates of congestive heart failure admission in the United States for our people on Medicare. What you may not know is that 1 out of 4 are rehospitalized in 30 days after they're discharged. All right? So you see here, 24% get readmitted, and all those expenses across the top are avoidable expenses if we keep the patient out of the hospital. Now, how would you keep the patient out of the hospital? Anybody here from Searcy? White County Medical Center has actually had one of the highest readmission rates in the nation for congestive heart failure. They were in the penalty box by Medicare. Medicare was going to cut their hospital payments. So they invested in a home health nurse, electronic scales, and some dietary education. And actually at discharge, within 3 days now for congestive heart failure, a home health nurse goes home to make sure that the new prescriptions you wrote and the prescriptions they already had, there's some reconciliation for what those are. They do a dietary education so that they cut down on salt, and they give them an electronic scale that plugs into the wall and into the telephone. And every day they step on that scale, and there's a nurse manager back at the hospital looking at the hundreds of people that have congestive heart failure that have come through Searcy. And when Mr. Smith starts gaining weight, they call him up and say, Mr. Smith, are you watching your salt? Do you need to take an extra Lasix pill? Is it time for us to see you, or do you need help somehow to avoid this whole readmission 24% on the top? Now I'm going to try to show you something.
I came to home health from the hospital. I was having to go to the hospital just real often from heart failure and different things. And when I got released, well, they started coming out. And it was a great help to me because they took care of me at home and did my blood work here a lot of times, and I didn't have to go to the doctor for that. They just kept checking on me, and I got better. Haven't been to the hospital since last August. So for me, that's a record. I've got a little job. I babysit for my great-grandkids and cooked supper for my son and daughter-in-law, and just everything, anything and everything I want to do, I do it. Well, my diet, I have to watch my diet, of course, and just how to take my medicine, keep a record of it, and you know, if I get too heavy, I know to take extra pills, and if I don't, well, I don't have to. So they called and checked on me, and they got a report twice a day through that, and of course that helped them keep in touch with how I was doing, and if my medicine needed adjusting, or if I needed to go to the hospital or the doctor, or have someone come out here. That helped a lot. So the little machine sometimes would get on my nerves if I wasn't wanting to be bothered with it, but I was glad to have it too.
So let me go back to this slide. In the fee-for-service system, when that woman went back to the emergency room and got hospitalized over and over again, we kept paying the bills. Okay? Kept paying the bills. Doctor got paid again, hospital got paid again, pharmacy got paid again. In our new system, and we'll come to it in a minute, avoiding that hospitalization, half the savings end up going to the quarterback. All right? And it, for the first time, aligns the financial payment with getting the best outcome and knocks down all the barriers to try and, no pre-authorization, you don't have to get approval for the scale, no home health pre-authorization, it's whatever's going to work for the patient to get the best outcome. Now the financial incentives are in place to make that work, and for the quarterback who does a good job, the revenue is going to be optimized. Not for the person who now invests in the telephone call and doesn't get paid in fee-for-service. So it's going to totally shift the financial incentives from utilization of services to maintenance of health and better health outcomes. And the primary care setting is going to be the place that has the best savings from that. Now let me go to episodes, because primary care has a few episodes, but this is really going to hit the specialists the most. Think about an episode of any condition: a heart attack, a hip replacement, a congestive heart failure hospitalization, something that has a big investment of effort and resources. Right now there's no quarterback. Everybody's doing their own thing. Y'all see it all the time in the current clinical care system. Well, what we've done is we've actually started out and are live with 5 episodes. We have 5 episodes that went live last July. Total pregnancy, attention deficit disorder, hip and knee replacement, heart failure hospitalization, and upper respiratory infections. Now over on the right, sorry, I didn't get the right, so let me go through it. Pregnancy and delivery. The episode is from the time the woman starts her pregnancy to 2 months after delivery. And the quarterback is the delivering physician. In the future, the delivering physician is going to be held responsible for and get paid better if they manage the whole pregnancy to an optimal outcome. Now, what's happened already is under the fee-for-service system, you actually got paid the same if you did a 39-week induced delivery versus if you waited to 41 weeks when it was full term. Well, y'all know this, 39 weeks estimated gestational age. If you're off by a week and you're at 38 weeks, the baby's lungs aren't mature enough and you end up in the neonatal intensive care unit. If you wait till the natural process, the baby's lungs are going to be mature, you're going to avoid the neonatal process. So by aligning the payment incentives on the quarterback, the delivering provider, we just eliminated a whole set of service needs. And when those providers, the OBs now, are getting performance reports, and in January of next year, over 25% of them are going to get an extra check because they're doing the right thing. Another way this aligned up was we had an OB provider who was in the red zone. He was going to be penalized next year. He came in and said, why am I don't do anything different than anybody else. And we went in to look at his claims. Every delivery, the hospital had a standing order to send the placenta to the pathologist for a full pathologic exam, $1,500 pop. More than the OB got paid. All right? Now, y'all have done OB. You don't need to send every placenta for a full pathology. You need some, but the hospital was figuring out how to pay the pathologist. And in the fee-for-service system, nobody stopped to say, should we be doing this? Well, now I've got a quarterback on that OB team who say, wait, we don't need to do that. And you're starting to save the system. Now, it may hurt the pathologist, okay, but it's more appropriate for the system. Yes?
Could you just describe for a second about how that penalty zone?
Sure. So talk about the penalty zone and the bonus zone. Now, let me back up one step. Under patient-centered medical homes, there's no penalty zone. Okay? There's only upside gain sharing. If you do a better job and you make the system more efficient with good outcomes, you share in the gains. There's no penalty phase in that right now and not anticipated. On the episodes, what they did is they looked at all of a type of episode. So all the hip surgeries across the state. Blue Cross looked at theirs, Medicaid looked at theirs. And what they did is they said, you know, there's variation here that's not justifiable. Now, we have hospitals here in Little Rock that have a threefold higher infection rate than other hospitals. Okay? Post-op infection rate 3 times higher in one hospital that's less than 2 miles from another hospital. Health department can't tell us which ones that are because the hospitals have not wanted that information out. Okay? But, so if you're a surgeon practicing at a hospital where you have a higher infection rate and you have to do more reoperations, your average is going to be higher. But they set the thresholds, they lined all the docs up and said, here's your average for the episode. And they said the top 25 percentile are in the red zone, the bottom 25 percentile are in the green zone, and so the 50th percentile in the middle, plus or minus 25, are neutral. And they fixed that. So they basically said, if everybody gets down into the green zone, everybody gets an extra check. All right? But if people stay up here in the red zone, maybe we don't want you doing hip surgeries. All right? So it's going to drive people farther towards that center of excellence aspect that I talked about with Walmart. But they fixed the thresholds, and now over time we're going to watch people migrate to get into the green zone so that they can get that extra paycheck. So real quickly, we're about to run out of time, but so pregnancy and delivery is the pregnancy. Attention deficit disorder, it's a year of treatment. For hip and knee replacements, it's 30 days before the hip surgery to 2 months after the hip surgery. So right now, the orthopedic surgeons, all they really worry about is the hip surgery itself. They don't think about the rehab downstream or how many MRIs we got upstream. They will now. Heart failure, we talked about upper respiratory infection. It's the diagnosis of an URI in the next 21 days. When we looked at Medicaid's data, 50% of kids that were diagnosed with an upper respiratory infection were put on an antibiotic the first time they were seen. Okay? Not appropriate care, but back to the education question we had. It's a lot easier for me in the fee-for-service system to not spend the extra 5 minutes with the mom for why her kid does not need the antibiotic than it is for me to just write the prescription and go to the next room. Well, now I've got an incentive to invest in the education. Oh, and by the way, if the mom doesn't like what I say and she goes to the emergency room doc has the same incentive. He will be in the red zone if he writes too many prescriptions that are not necessary. But we have quality indicators in place so that if they are necessary, they count for you. And so that's the approach that we've taken to try to get control and to try to reinforce some of the consumer education. So it's not just one doc by themselves, it's all the docs seeing folks for upper respiratory infection or all the hospitals for congestive heart failure. We've got new episodes coming online. We've got tonsillectomy, cholecystectomy, colonoscopy, and another mental health condition, oppositional defiant disorder. Later this year, we will launch the open heart surgeries and the percutaneous events. We'll do COPD and asthma. We'll end up bringing the neonatal experience into the OB experience, and we'll look at some of the comorbidities in mental health. You'll see these episodes are starting to pick off specialty by specialty. Okay? And the episode information should be available for you as a primary care clinician to know who to send your person to for the hip surgery. And guess what? Your patients, if you send them to somebody who gets better outcomes, ultimately that's going to be a better deal. And Medicaid, Blue Cross, Medicare are going to share the savings with you for sending somebody to the right place. So it's a totally different paradigm going forward. The payers' goals are in the next 2 years to have 80% of everything they spend either under an episode or under a patient-centered medical home. I think that's pretty aggressive. I think it'll be 4 years. But they are committed to moving away from a pure fee-for-service system to partner with the quarterbacks, whether it's a patient-centered medical home or an episode, and to pay for things in a different way. Let me just pause there, and what I want to do is close and say what I see. People ask me, why are you working with these insurance companies and Medicaid and Medicare? What they are saying is, let us keep what's called actuarial risk, the chance that lightning strikes me today, or I get hit by a bus, or I have a heart attack. They want that risk. But what they want to do is partner with the clinical leaders to say, let me partner with you to manage the clinical part of the process. Let's get away from pre-authorizations where you have to call in and say, can I get an MRI on somebody? You have formulary issues that are just trying to contain the cost of the drugs. Let's partner with the clinical community to say what y'all are in control of. You actually have an aligned payment incentive to do the best thing possible for your patient. Oh, and by the way, in the future, it won't be the specialists that have the greatest increase in return. What Andy told the Medical Society Board is he thought primary care clinicians, physicians in particular, could potentially double their income in the next 3 to 4 years. Now that made the specialists sit up straight, made the primary care docs nod their head. All right? And so anyway, let me close there. I'll be glad to take any questions. I'll stick around for a while if folks have things they have to get to. I'm excited. I think Arkansas is on the map. We got one of the largest grants from the federal government to pay for this payment innovation. There were 6 states that got it. Think about this on a U.S. map. Maine, Vermont, Massachusetts, Minnesota, and Oregon, and Arkansas. And I just go back to the Sesame Street saying one of these is not like the other. And we're farther ahead than anybody else. So thank you all for having me. I'd be glad to take any questions or help anyone. Questions about anything? Anything's fair? Yes, sir.
Yes, sir. I have a question about, you have the red zone for the specialists. Now, my fear is that in the future, what would keep that from being right now it's the highest 25% is in the red zone. So people get that squared away. In the future, there's a pressure to contain costs. The fear is they would keep re-indexing that number to the point that care would become compromised.
Sure.
What are your thoughts on that, sir?
So the commitment starting out is to hold it steady for a period of time. And I think the intent is over time as we get more and more efficiencies, because we don't know whether it's 10% inefficiency or 30% inefficiency in the system right now. What they set those thresholds on was seeing marked variation in what people were doing that we could not explain. So they risk adjusted away comorbidities, they looked at different things, and they found, for example, the low end, I'll just pick as an example, the low end average hip replacement was somewhere around $7,500 to $8,000. So a surgeon can do it on average less than $10,000. The opposite extreme, we had a surgeon whose average was $25,000. Okay? Now, I think you're right. When we move down out of 25, so let's just say the threshold's at 20 and 10 right now. When we get everybody below 20, we ought to relook and say, are there things that people that are on average costing $19,000 a year doing that they shouldn't be doing? Or should we increase the green zone because these guys have really done a really good job? What the thresholds kind of do, if you think about it, it's net neutral to the system. It's trying to get everybody where they're doing a very good job and we're paying everybody fairly, where right now, just want you to think about it, the orthopedic surgeon who practices at a hospital that has a high infection rate. So in other words, they have to go back in and redo the surgery more times. Both the hospital and the surgeon are paid more than the orthopedic surgeon who gets it right in a clean hospital the first time. That's wrong. We ought to be paying the good guy more. And so I think your question is a valid one. And actually in the last legislative session, they set up a legislative committee to review the threshold setting when that happens in the future so that there's a public process. It's not behind a closed door. We had a public process this time, but it wasn't quite through the legislative piece. So I think your question is a valid one. I think the intent is to partner with the clinicians. And so if it becomes one-sided, that partnership dissolves immediately. And I think you'll have a revolt on the physician side. Yes?
It's kind of in line with that. Who's making these it a bureaucratic section, or is it kind of going to be a new legislative mandate?
It's me with a little black box at home that I turn the thing up. No, it has been a deliberative process, and actually a fairly public process, in that we have done about 30 town hall meetings across the state. We did one here last week for the patient-centered medical home. The Medicaid program has to go through public rulemaking through the legislative process, so they have to tell the legislature what they're going to do, and then they have to have a period of time where people get to comment, and then we go before the legislature to put that in place. The private sector does not have as much of a requirement until this legislative piece got put in place to require the public discussion of the thresholding piece. So I think it's a public process. I will say most clinicians are either not aware or not fully engaged on that public process. Now, your medical society is, your Academy of Family Physicians are, I mean, your associations are, but I hope that, you can track it off of our website at achi.net. If you Google Arkansas Payment Improvement, there's a payment improvement website where the rules are put up there. I won't say it's the friendliest website to navigate, but that's where I would start paying attention for some of these changes. And I think the patient-centered medical home rules will be out in the next 30 days, so you'll probably see those coming out. Yes?
You talked about ranking the specialist doctors that would be available to the primary care physicians. Would those rankings, that information also be available to the public, or is it simply going to be physician information?
Kind of depends on how much legislative interest there is in having transparency in the system. Right now, it's not available to either physicians or to the consumers. And I think, you know, we as clinicians don't like somebody looking over our shoulder to say, are we doing a good job or not? But I think it's coming soon to where not only will that information be necessary to be available for primary care clinicians, it'll be necessary for consumers too. I get phone calls from people who don't have insurance that say, where can I get my knee replaced for the least cost? I don't know that information, but I think we're going to increasingly have that information publicly available and transported. Yes? Go ahead.
So, I mean, if your reimbursement's based kind of on a ratio on outcomes and then also how much you're spending to get those outcomes, then when you have a non-compliant patient or you have somebody that starts going downhill, I mean, you can like put a lot of resources into that, or if you just know that you're not going to get reimbursed, like what's the motivation when you have a patient like that to keep treating them?
So in part, I'll come back here. Yep. So, no, I mean, we have intentionally thought through this to make sure that, you know, clinicians don't dump patients. And actually the per member per month payments are risk adjusted so that you could, as a physician, say, well, I only want healthy people. But probably your per member per month payments are going to be the lowest that they could be. And let me come back to the issue. The gain sharing, the sicker patients are going to be having more problems on how the system is not working for them. So the way to get it right is to get it right for your sickest patients, and that's where you're going to have the most revenue in the future, is by getting it right for the sickest patients. The woman with congestive heart failure, she was not overly healthy. But think of the hospitalizations that were not happening and the savings that are available or will be available to either the hospital or the primary care clinician because somebody's actually got a home health person, not the doc going to the home, but a home health worker or a health educator or somebody else that's actually offloading from the physician a lot of what we are not that good at anyway right now. We're trained to take care of people that are sick. We're not trained necessarily to be educators, but there are people that are trained and a lot less costly than us. But I think to your question, I think the gain sharing will end up being risk adjusted so that you can't game the system. You probably can game it a little at the margin, but the reality is you're going to end up investing more time in sicker patients and having more rewards for getting it right. Yes, sir.
Dr. Thompson, I was just wondering if you could talk a little bit about how do you measure if some episode of care has been avoided? How do you measure that savings, for something that hasn't happened?
So the ultimate question, if you take it to this, how do you know that prevention worked when the event never happened, right? The health insurance companies are incredibly adept at looking at the claims record of the past and predicting what your claims are going to be in the future. That's how they've been making money for a long time, because that's what sets your health insurance premiums. Now, that's illegal under the Affordable Care Act. Can't use pre-existing conditions to set insurance premiums. But I think we're increasingly able to, with some statistical certainty, and you know, it's management of your population of patients as opposed to managing the people who are coming to visit you. And you get a large enough pool, and right now the statistical number is around 5,000. Not 5,000 visits, but 5,000 patients that you have on your panel. So if a doc has 2,000 patients, we're talking about a practice of 2 or 3 docs together being a pool, and that pool gives enough statistical certainty to be able to say, this clinic is having more risk-adjusted expenditures than they should, or this clinic is doing much better than we would expect them to do otherwise. So it is about, and again, this is a shift, and I would encourage any of you who have a chance to take just an introductory course to epidemiology to think about it. Because I didn't get any of it when I went through medical school, and when I looked at y'all's curriculum, you get a little bit of taste, but not much exposure. This fundamentally for the primary care team is not thinking about who's on my patient visit list that I'm going to see today, although that's part of it. The new part is who's on my panel who's probably sick that I haven't seen in a long time, and how do I get them in so I avoid the congestive heart failure hospitalization? How do I use technology in a new way? That scale, $30. All right, electronic scale, $30. One hospitalization, 17,000. Y'all do the difference here, okay? There's a huge margin for somebody to come in and totally revamp clinics across our state and to start really both getting the best outcomes, probably having more fun than the gerbil on the wheel right now, and making more money. So I just put out there, I think primary care has a very, very bright future. I'm not sure it doesn't have the brightest future, because we got a lot of specialists doing a lot of things in a lot of places, and you're going to see a concentration into these centers of excellence that become much more like factories, because volume is associated with quality. Those orthopedic surgeons that were on the higher end, they do fewer surgeries. They're longer in the OR. They have more complications. When you need your hip surgery or your knee surgery, first question you ask, have you done more than 100 surgeries on this? All right. High, statistically and scientifically reliable information. You're not good until you do something 100 times. All right? Now, that's why you should tell your family and friends, don't come to UAMS on July the 1st, the first week the interns are on. But by the end of August, it's not bad. All right, so another question. We had a question back here I didn't get to. Did we get? All right. Yes.
You talked about these quarterbacks.
Yep.
But in regards to the medical homes, what specialties are the quarterbacks? Is it only family practice and pediatricians, or internal medicine, or GYN?
We had this question come up by the medical board as the specialists want to know how they could be quarterbacks. I think it's predominantly people serving as a primary care clinician for total care. So it would be family physicians, it'd be pediatricians, it would be some internists who have more of a complex, complete patient management. At the Medical Society board, I did have a hematology oncologist who they do a lot of short-term intensive majority care for patients. They say, well, can't a hematologist or an oncologist be a patient-centered medical home primary care provider? And we said, yes, you could if you agree to do everything that the primary care provider does. Shots, preventive screenings, the management of the diabetes, not just the management of the cancer. If you can ante up and say, I want to be a primary care clinician, I don't think it's what many specialists are going to want to do, because they're going to need to specialize and get good at what they do. But for the family physicians, pediatricians, the internists who choose a primary care route and a non-specialist route, I think those are they. There may be periods, for example, when you're pregnant or when you have cancer or when you have select conditions that really are intensive in a specialty area, that the primary care physician plays a lesser role. But you want to make sure that that patient who's your responsibility is with the best specialist you can find for the condition that they have. All right, thank you all very much. I'll be glad to stay. And I'm on the UMS Global email. If you have a question or something, let me know. Thank you for having me this afternoon.